Hello and welcome to another session of KLAS Report Insights. We're delighted to have you with us today, and also equally delighted to have Kathy McCabe with us today. Kathy, thanks for joining us.
Absolutely, happy to.
Well, today we're going to be talking about a new report that you've done on downside risk leaders. Now, give us a little background on this report. What are you doing with the report, and what did you hope to accomplish with it?
This is a really interesting report. It's unusual from most of our reports where we look at the whole industry. In this case, we actually went out to vendors and asked them who that you work with is doing the best job moving towards downside risk, because we really wanted to understand who the leaders are, what they're doing that's different from other people who are implementing population downside risk, and wanted to be able to learn from them. One thing we've noticed working in this industry is that we're not as far along down the population health path as we thought we'd be by now. So we wanted to really dig into why that is and what are those differences that other people could start to implement. So these were really in-depth case studies where we talked to 15 different providers, and usually 2 or 3 people from each provider for about an hour each. So a lot of depth. So very unusual from most of our reports.
Yeah, very different from, I'll call it the classic KLAS report.
Exactly.
Probably classic with a K even.
Absolutely.
So that's fantastic. But it's interesting because when we think about downside risk and risk in general, the move to value-based care has definitely been slower than we thought it was going to be. You know, if you look back at 2000, we'll just say 10 years ago, we all thought we'd be a little bit further along than we are right now in downside risk. So, fantastic that you went and talked to these organizations to find out what's going on. Probably hard for some of these vendors to say, yeah, these are the 2 that you need to talk to, because there are a lot of great organizations out there.
There are a lot of great organizations out there. So they really dug in a little bit deep into their files to say who should you really talk to, and ask them if they'd participate. And so it was really great that they were willing to give us that much time so that we could learn from them, because we got just amazing insights from them.
So Kathy, one of the great things about talking to all these downside risk leaders is you're probably able to get some great best practices for ways that they've been able to take on downside risk. Could you share some of those with us?
Absolutely, happy to. When we talked to all of these providers, one thing that we noticed were there were basically 3 overarching characteristics that all of them shared, and these were key to their success. The first was they had a really great relationship with their vendor. So regardless of who they were working with, if it was Arcadia or Epic or any of the other great vendors out there, they worked with them collaboratively, because it was early on. They were learning, oh, I'm going to need this application, I'm going to need this functionality. And so they were able to work really cohesively with their vendor to get the most out of what the product offered, as well as either build onto it or bring in their own resources to capitalize on what they already had. So there was that complete buy-in, and the vendor was absolutely supportive. So that was really important. Secondly, what we also saw was that they had complete buy-in from the organization, from the top down. So your CEO, it's critical, because you obviously know the board has to be involved and the CEO needs to be buy into it, but you also have to have the financial people to understand that, value-based care doesn't turn around your profits or turn around your income in a year. It's a long-term proposition. So you have to be prepared to build that up and know what to expect. So those people are important, and then your doctors and your physicians are critical, because it's a totally different way of doing business. It's a totally different way of practicing medicine for them. So they have to be bought into, I'm going to care for the whole patient and not just a broken arm, if you will.
That makes a lot of sense, because you have the entire organization that has to change, because it's a fundamental change in business model. Instead of a fee for service to go for, an capitated contract, a a fixed amount per member per month or per member per year, then you have to worry more about attribution than you do about who's being seen.
Exactly.
So, okay, well, that's really interesting, Kathy.
One of the providers, had a great way of putting it. He's like, it's like having a foot in each canoe. You got your fee-for-service canoe, and then you've got your value-based care canoe. And it's hard to, if you can envision that, going down the river, that's a tough place to be. So you have to have everyone on board to be able to make it work.
And hopefully you're just not going towards a waterfall.
Exactly. And then the third thing is they're really starting to work with their payers. So the insurance companies and the people who are paying the bills, they're working with them to try to figure out, what's the right reimbursement for this? What can we agree on? So they're moving past just the CMS model and coding to go to that next level to really be able to take on more risk. So that's another thing that they're doing.
And there's been a lot of friction there in years past between the payers and providers. So having that collaborative relationship sounds like that really changes the game.
Mm-hmm. It really does. And by the providers being able to have the claims data, which has been a key part of being able to go to population downside health, they're able to use that data and share it with the payers and say, this is what we're showing. What are you showing? Where are we different? Where can we agree? And I don't want to overstate it. That relationship still isn't where it needs to be, but certain providers and vendors are getting there. So there's definitely hope for the future there.
Okay, well, that's fantastic. We love hope for the future.
We do.
Because things can get better, and we really want them to get better. Not just for all us Americans, but for the whole world.
Absolutely, we do.
So Kathy, in these interviews, I know that sometimes we ask for, best practice advice, or, if one of your peers were getting into this, what kinds of things would you want them to know? Did we ask that to these organizations?
Absolutely. And they were so willing to tell us all the pitfalls they had been through and what to look out for. One of the most interesting things that I think came out of it was that the people who are further down the path are really moving past CMS and getting into the capitated contracts and so forth. And their biggest piece of advice was know your contracts. Really be sure that you know the fine print, that you know what you're agreeing to, make sure you know your population, and can you really deliver on what you're signing your name to? One of the big things also was that try to make your metrics the same across all of your contracts, because these larger organizations, they may have 12 contracts they're working against with different ACOs, different payers, and so forth. And if you have a different, say, diabetes measure for every one, it's an administrative nightmare to take care of. So try to make your contracts as payer agnostic as possible and make them advantageous to yourself so that you know those are measures we can really hit. And then your whole staff is working towards the same goal. So one group's not working on metrics A, B, and C, while another group is working on D, E, and F. So that was a really interesting finding that people gave us that I don't think we had really taken full appreciation of yet.
Yeah, and one of the really interesting things that came out of that is that if you go to the payers and say, hey, here are the metrics that we're focusing on in our other contracts, is it okay if we do that in this contract too? The payers say, yeah, that works for us.
Some of them did. You might get a little pushback, but you can make your case then. At least you have the data to back you up and you know what you can do. So you want to still make contracts that are advantageous to both parties.
So speaking of data, I know that's a really big focus for the industry. Any advice or best practices from these downside risk leaders about data, both aggregation and the analysis of that data?
So they've come a long way in getting data. Obviously, I've already mentioned claims data has been key to being able to make this work. But that said, there's still improvements that can be made. When you think about it, you're getting data from so many different areas. You're getting it from various EMRs out there. So, if you're in a network, you may have 6 or 7 different EMRs coming into your data system. So the ability to get all of that standardized to come into your system so that you can work with it has gotten better, but we still have a ways to go on that to make it easier and more streamlined. And then we also need more predictive analytics, more ways to provide actionable reports that really show how well you're doing. So we've come a long way in that, but we still hear from providers that they would want more.
Yeah,
more, better, faster.
Absolutely. So, because as you move down that journey of having the data towards insight and then to action, there's a lot that you can do to move down that journey. And I don't know if we'll ever be at a point where everybody's happy with it, but hey, we're making progress.
We're moving in the right direction, for sure.
Kathy, thanks so much for being with us today and sharing these insights with us.
I was happy to.
So this and all our other reports are on KLASresearch.com if you'd like to read more, especially about these downside risk studies that we've done. Also, if you have particular questions, you can email us at info@KLASresearch.com, and Kathy or myself or a member of our team will be happy to answer those questions for you. Thank you again for joining us, and hope you have a wonderful rest of your day.